Hello, welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today we have the collaboration of Dr. Carlos Ortiz, clinical cardiologist assigned to the heart failure unit of the Hospital Gregorio Marañón. And together we will review everything you need to know about the treatment of acute heart failure in those patients with concomitant kidney failure. Join us! As you know, few organs have such a close relationship within the human body as the heart and the kidneys, since the preload depends on the regulation that the kidneys exerts on the plasma concentration of sodium and the volume of the extracellular space, while, for its part, renal function depends in turn on cardiac output and adequate perfusion pressure. Thus, the treatment of acute heart failure in patients with concomitant kidney disease can be one of the most complex situations in our clinical practice, not only due to the fact that both organs fail simultaneously, but also because some of the most used therapeutic measures in cardiology can negatively affect kidney function. But don't worry, with today's video, we intend to make things a little easier. Let's get started. The first thing we need to know is that patients with heart failure suffer from kidney failure in up to 50% of cases, and that 1 in 5 of these patients will suffer from advanced kidney failure. In addition to being prevalent, concomitant chronic kidney disease has a negative impact on the prognosis of patients with heart failure, being an independent predictor in the short and long term of mortality and cardiovascular events, with a worse prognosis associated with the more advanced stages of kidney disease. However, as you can imagine, this relationship between heart and kidney is not unidirectional, since the presence of heart failure is associated with a significantly higher risk of suffering from chronic kidney disease, which implies not only a deterioration in the glomerular filtration rate, but also an increase in overall mortality. In this way, it is evident that the heart and kidneys are closely related, and that, for this reason, we cannot undertake the treatment of heart failure without considering its renal repercussions. So, how should we act when we have a patient with acute heart failure in a state of frank systemic congestion and who also has kidney failure? Well, roughly, we recommend acting as follows. 1. Eliminate fluid overload. 2. Ensure adequate renal perfusion pressure. And 3. Adjust the neurohormonal blockade. With that said, let's take a look at each of these recommendations. Let's start with the volume overload. As you know, the intravenous administration of loop diuretics constitutes one of the most important therapeutic pillars in patients hospitalized for acute congestive heart failure. For this reason, the administration of these drugs requires some skill and experience. And if you don't believe it, wait a bit. Let's start with furosemide, one of the most widely used loop diuretics today. In this case, we must not only choose the appropriate dose, but we must also choose the most appropriate route and form of administration. But how to do it? Well, don't worry, we're not the first to ask this question. So let's take a look at the DOSE study. The DOSE study was a randomized prospective double-blind 2x2 factorial clinical trial which recruited 308 patients hospitalized for acute congestive heart failure in order to identify the most effective and safe regimen of intravenous furosemide. In this way, continuous infusion of the drug was compared with the administration of bolus every 12 hours on the one hand, and the administration of a low dose with respect to a high dose on the other hand. The primary endpoint of the study was determined by detecting changes in patient symptoms and in plasma creatinine concentration, and although there were no significant differences with respect to the primary composite endpoint, it was clear that the administration of high-dose intravenous furosemide achieved more favorable results with respect to several secondary endpoints, for example, improvement in dyspnea, weight change, and the net volume loss. Now, after administering furosemide, it is worth asking ourselves, how can we determine if we are achieving the desired therapeutic effect? Well, very easy, through fluid balance and body weight change. Very simple and classically used measures in order to estimate the diuretic efficiency. However, it is a fact that the calculation of the water balance can sometimes be inaccurate, and that the change in weight does not have to represent a redistribution of body volume. For these reasons, indicators of diuretic response are becoming increasingly important in clinical practice. In this way, measurement of the urinary sodium concentration in a urine sample obtained 2 hours after the administration of loop diuretics has shown an excellent correlation with the 6-hour total urine sodium excretion. Thus, by means of this test, we can affirm that the diuretic response is adequate when the urinary sodium concentration is greater than 50 milliequivalents per liter. But this is not all, since a diuresis rate greater than 100 milliliters per hour during the first 6 hours of diuretic treatment, or a urine volume greater than 3 liters in the first 24 hours of treatment are also clinical indicators of a good diuretic response. And as you can imagine, this is very important because the determination of diuretic efficiency not only allows us to identify patients with diuretic resistance early, but also has prognostic implications. Thus, it has been shown that patients with poor diuretic efficiency have a higher risk of mortality, impaired kidney function, readmissions for heart failure, and heart transplantation. But what is that about diuretic resistance? Well, simply put, diuretic resistance can be described as an inadequate amount of natriuresis despite an adequate diuretic regimen. However, this definition is subjective and varies depending on the clinical context, hence the importance of quantitatively defining diuretic efficiency. In this way, the mechanisms responsible for diuretic resistance have been grouped under the term diuretic braking phenomenon, some of the most important being cardiogenic shock, congestion of the renal venous system, increased intra-abdominal pressure, the low concentrations of diuretics at the level of the loop of Henle, and the compensatory reabsorption of sodium due to the hypertrophy of the distal convoluted tubule. However, it should be remembered that not all episodes of heart failure present with cardiogenic shock, and for this reason it is important to emphasize that mild or moderate alterations in cardiac output do not usually trigger resistance to diuretics, which is why the treatment with vasodilators such as dopamine and milrinone in hemodynamically stable heart failure patients has not shown benefits in terms of increased diuresis and weight loss. Well, now we know that the indicators of diuretic response help us identify resistance to diuretics. We also know that, in addition to cardiogenic shock, one of the most important mechanisms of resistance to diuretics is renal venous overload and systemic congestion. Well then, we only have to know how to treat this entity, and for this, we bring you the following recommendations. 1. If we assume that systemic congestion is the common mechanism of kidney failure in heart failure patients without cardiogenic shock, it is easy to understand why we should begin by restricting salt and fluid intake. 2. The next step is to titrate furosemide at high doses, at least 2.5 times the patient's usual dose, and avoid excessive inhibition of the renin-angiotensin-aldosterone system, since arterial hypotension can aggravate the problem. 3. If resistance to diuretics persists, furosemide could be changed to torsemide, since the bioavailability of this drug is higher. This translates clinically into a reduction in dyspnea, hospital readmissions, and mortality from heart failure. 4. If urine output does not improve, the nephron could be sequentially blocked, combining loop diuretics with another family of diuretics. Thus, the first choice is usually thiazides, as this drug combination effectively blocks the nephron, regardless of the molecule chosen. Another option may be the combination with high-dose mineralocorticoid receptor antagonists, that is, more than 50 milligrams per day, since with this dose a more powerful natriuretic effect is achieved than that described in clinical trials. Finally, other diuretics such as acetazolamide and tolvaptan could be useful in patients with metabolic acidosis or hyponatremia respectively, although the clinical evidence is not conclusive. 5. Then there are the SGLT2 inhibitors, a family of antidiabetic drugs that are very popular today, since they not only have diuretic effects, but also improve the prognosis of patients with heart failure. And for this reason, they have recently been included in the neurohormonal treatment of this entity, although its impact on resistance to diuretics is a subject that is still under study. 6. If diuretic resistance persists, the administration of hypertonic saline solution could be considered, since the osmotic extraction of free water from the interstitial fluid to the renal vasculature not only increases renal blood flow, but also improves the supply of sodium in the loop of Henle, and so restoring some of the effects of the loop diuretics. Thus, several studies have shown that adding hypertonic saline solution to loop diuretics improves urine output, kidney function, shortens hospitalizations, and reduces hospital readmissions and mortality from heart failure. 7. Then we have the subcutaneous infusion of furosemide, a therapeutic measure that has shown a reduction in hospital admissions and symptoms in some observational and single-center studies, with a low rate of adverse events. However, as you can imagine, randomized studies are necessary to confirm this data. 8. Now it's dopamine's turn. As you know, the administration of this drug at low doses failed to demonstrate clinical benefits in the ROSE HFrEF study. However, the subgroup analysis suggested possible benefits in patients with reduced ejection fraction. Well now, although dopamine has no proven benefit in resistance to diuretics, it can be used as a last resort in these patients given its theoretical benefits. 9. Neseritide is a recombinant B natriuretic peptide approved by the FDA for the symptomatic treatment of heart failure. Although small clinical trials have shown favorable effects of the drug on hemodynamics and dyspnea in patients with heart failure, the truth is that the largest clinical trials, such as ROSE HF and Ascent HF, could not show that neseritide had relevant benefits with respect to diuretic resistance. 10. Finally, in cases of severe systemic congestion refractory to medical treatment, we could consider ultrafiltration and peritoneal dialysis. Let's start with ultrafiltration. In this case, we must say that the results obtained in clinical trials are contradictory, since the clinical benefits of the therapy have not been fully demonstrated. However, we must point out that the inclusion criteria and ultrafiltration protocols were different in each study, and for these reasons, these contradictions could be justified. On the other hand, various observational studies have shown that peritoneal dialysis is capable of reducing the weight of the patient, improving functional class, improving quality of life, and reducing the number of admissions and hospitalization time for heart failure. Great! We already know that loop diuretics are essential for the treatment of fluid overload in patients with heart failure. Furthermore, we have seen the importance of certain clinical tools known as diuretic response indicators, and finally we have learned to identify and treat the phenomenon of diuretic resistance. Now it is up to us to change the point. Then let's talk about renal perfusion pressure. As you know, creatinine, glomerular filtration rate, and diuresis are necessary clinical tools to identify the deterioration of kidney function. So, as you can imagine, we can sometimes see an increase in serum creatinine levels in patients with acute heart failure who are being treated with diuretics. For this reason, sometimes the clinician is tempted to decrease the doses of diuretics in order to avoid further damage, since they have the false belief that diuretics are responsible for kidney damage. And the truth is that this does not have to be that way. Let's see. At this point, it is necessary to know that the increase in serum creatinine and the fall in the glomerular filtration rate can lead to a decrease or not in diuresis. In the first case, we would be talking about a true deterioration of renal function, while in the second, we would be talking about a pseudo-deterioration of it. And this is important because the pseudo-deterioration of renal function derives from systemic congestion. It is treated with diuretics and has a better prognosis. On the other hand, the true deterioration of renal function is something else, since the drop in diuresis could be the result of a low renal perfusion pressure, and for this reason, it is necessary to suspend hypotensive drugs consider the administration of inotropic drugs at low doses, and even consider circulatory support measures. Finally, let's talk briefly about neurohormonal blockade. As you know, many of the most famous clinical trials conducted in heart failure patients with reduced ejection fraction excluded patients with severe kidney disease, so clinical trials conducted in patients with heart failure and concomitant kidney disease are rare. Therefore, the recommendations are often based on extrapolation from populations with a small sample size in observational studies or in clinical trials conducted in patients without advanced kidney disease. However, a meta-analysis has recently been published that included 26 studies and almost 20,000 patients, which suggests that in patients with heart failure with reduced ejection fraction and chronic kidney disease, the effect of inhibitors of the renin-angiotensin-aldosterone system is uncertain in terms of mortality and hospital admissions. With regard to beta blockers, it appears that they may reduce the risk of all-cause mortality and the risk of hospitalization for congestive heart failure, although the quality of the evidence is moderate at best. The effect of mineralocorticoid receptor antagonist is also uncertain in terms of mortality, with the added risk of developing hyperkalemia. Finally, the clinical benefit and safety of sacubitril valsartan in patients with advanced kidney disease is unknown, but there are clinical trials that suggest that the deterioration of kidney function is lower than the ones seen with ACE inhibitors. And little more to say. As you can see, chronic kidney disease is an independent predictor of cardiovascular events and mortality in patients with acute heart failure. Therefore, it is important to monitor diuretic efficiency and renal function during decongestive therapy, as this has prognostic and therapeutic implications. And although there is no doubt regarding the importance of treating systemic congestion with diuretics and of guaranteeing adequate renal perfusion pressure, the adjustment of neurohormonal blockade still lacks conclusive clinical evidence in these patients. In this way, we say goodbye. It has been all for today at Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!